this will be the best way that we're going to do this. And I will screen share here. And I just want to confirm, can people see the talk MHS Genesis 101? Is that on everybody's screen at this point?
Yes, we can see it.
Excellent. And I know there's a presentation view here. Here we go. We'll start there. Hey, so good morning or good afternoon, depending on what time zone you're in. My name is Alex Holston. I'm a Chief Medical Informatics Officer at DIMSM Program Management Office. So I'm assigned to DHA, but I work on the acquisition side of things, meaning we buy stuff for clinicians, providers, and the MHS as a whole. I'm also a neonatologist at Walter Reed, and as said at the beginning of the call, I'll be PCSing here shortly to Portsmouth, Virginia, and working as a neonatologist, again, full-time there. I'm excited about that opportunity. MHS Genesis 101 is a slideshow presentation given to our commanders prior to MHS Genesis coming. This, just for your information, this presentation itself is a sort of hour-long version. The actual presentation is about 2 days worth of content. I trimmed that down to about 40 slides to give plenty of time for questions and discussion at the end. I know it's a mixed audience, so I already see that some people have MHS Genesis, so keep me honest when we're giving this presentation, and feel free to interject with comments, concerns, or questions throughout. And if you do have questions, we will have time for it at the end, but if something comes up, just go ahead and raise your hand. I should be able to track everybody's hand raised, have teams up in a separate screen. Otherwise, let's go ahead and get started. So MHS Genesis is coming. We are actually at about half of all MHS sites at this point. And the important part as we replace our legacy informatics technology system is that in order for MHS Genesis to really work, we're going to need to lead through the change. For those that have already transitioned to MHS Genesis, they understand that the IT portion of what this is, meaning the system itself, is just one part of it. But people, policy, and technology need to line up in order for MHS Genesis or the transition to go smoothly for our patients and our providers. Before we get to what MHS Genesis is, I want to talk about what we're leaving behind. So I'm a digital hoarder. What does that mean? Like my parents who hoarded everything. Like I found a bottle of wine that was 15 years old in my parents' basement. Turns out wine doesn't keep well in a basement if it's kept standing straight up, just a point of information. So I don't hoard the same way. I hoard electronic files and keep them forever. Rhett, if you remember PWAD, I still probably could find a copy of PWAD somewhere out there in one of my files, obviously secured because it's kept secure. But when digging through my files, I actually found a survey that was issued back in 2009 to providers throughout the Navy at that time, because we weren't as tri-service. So this was simply through Navy providers. And their number one complaint was our electronic health record. And then parking shortly after that. So parking, maybe it's gotten better at your site, maybe not. With remote working, maybe for those who are able to when they're not in clinical care, it's gotten better. But in general, everybody was concerned that we had such a fragmented system of our electronic health records. We had Alta for outpatients, CHCS for ancillary largely, although some places were using it to document as well. We had CHCS for revenue cycle, so largely using that for coding and scheduling. And then we had Accentris for inpatient, and a lot of you guys still do. And the complaint was they were having to bounce back and forth from system to system to system. So this is a good reminder of how complex what we're leaving behind it really is when you get behind the scenes. It's just a lot, it's too much, it's time to put something newer because you guys, or at least the people who came before you, or maybe those of us who are still in 2009, asked for the change. So what are we changing to? We are trying to enhance patient safety, reduce unwanted variation, really become highly reliable, standardize our processes, enhance readiness, and better system performance. And those are all buzz lines. So let's translate that into what we're really hoping to do. So there are at least 2 neonatologists, and that's my comfort zone, is talking about my clinical experience. So I'm going to talk about neonatology. So when I went from Portsmouth to go TAD to San Diego this would have been almost a decade ago. It took me a week just to relearn all the workflows and IT systems at San Diego. And then I had a really good, solid week where I felt like I was contributing at that time to clinical productivity. So 50% of my time TAD out in San Diego was spent just learning the workflows. Neonatology, and yes, there is variance in local practices, and there are slight things that we do differently coast to coast, provider to provider, practice to practice. But the IT portion, the workflow portion, that should largely have been the same, and it shouldn't have taken a week for me to learn neonatology workflows and IT workflows at San Diego. Moving people around isn't going to change. I remember the old adage, I made the mistake, huge mistake, that when I showed up at Portsmouth Naval Hospital as a new attending, I said, I'm so glad to be at Portsmouth. I'm a neonatologist. I'm finally never going to move in the Navy because you guys never move neonatologists. And that was a huge mistake to state, because since then I've moved just about every 2 to 5 years as a neonatologist, and I've had a rather enjoyable career. But again, every time I move, I'm having to relearn the IT systems in order to provide care. And TAD, yes, 50% of that time TAD is important, but even just in the frequent turnover, it's hard to sit there and relearn a system when really we should have standardized processes throughout. So if our goal is to improve and deliver high quality healthcare delivery, to improve usability and have one record, MHS Genesis is our tool to do it. MHS Genesis replaces our legacy systems across the military health enterprise. It improves availability of electronic health records to support, and we have 9.5 million Department of Defense beneficiaries and 205,000 people working globally. It enables an application of standardized workflows, and we'll talk about what a workflow is. It's not really a term that we use on the clinical side too often. It allows for integrated healthcare delivery. We'll get into that. And then for those of us who are kind of into the data aspect and analytics part of things, it allows for data standards and improved secure electronic exchange of those data standards, and more importantly, patient data. So when we say MHS Genesis, that's a term that we apply to the entire enclave of the electronic health record that we're getting. The functional areas that it covers: primary care, specialty care, patient portal or patient experience, its inpatient capabilities, laboratory, pharmacy, radiology, dental, reporting, hospital administration, surgery, musculoskeletal and rehab, behavioral health, occupational health, emergency medicine, and then we're also expanding to revenue cycle. So it's everything. Now, what it isn't is one tool. So often when we talk about MHS Genesis, people are expecting to click on an icon, and we do click on an icon and it opens up MHS Genesis, but then we get to a storefront. And behind that storefront is a number of different applications that, depending on your role, that you're going to see. So I'm just going to go through a few examples of what those applications are. So for those that are on the inpatient or ambulatory side or subspecialty side, most of our documentation is done within PowerChart. PowerChart is a Cerner product that we use as part of MHS Genesis to document most of the care that is delivered. I consider this to be our ambulatory outpatient and inpatient suite, where if you think of what Alta and Accentris were, this has become PowerChart. On the ER side, Navy Medicine, depending on where you went, had a number of different electronic health records that people would use. The most popular was the Accentris ED that was used largely on the West Coast. Paper charts were used at some places, and we had a third-party electronic health record that was used at Portsmouth at times and then at Camp Lejeune at times as well. All of those are replaced by FirstNet. FirstNet looks a little bit like this. This looks and should look familiar as a tracking screen, and different from PowerChart, which is mostly patient-centric, where the patient's chart is pulled up in front of us. PowerChart or FirstNet is largely a tracking screen where you have what typically you would want to see in an emergency department on a tracking screen, which is the reason for the visit, the length of stay, who the physician is taking care of them, the nurse, technician, the different activities and events that need to occur, how much medications, IVs, labs, RADs, etc. By the way, you can see a number of patients listed here. This is a good point for me to stop and say all of this is synthetic or fake data. None of these represent actual patients. And these screenshots weren't taken in our production environment. Production environment is just a fancy way of saying the MHS Genesis that our patients and providers use. If you're doing anesthesia, we have an app or a module called SurgeNet. This allows our anesthesiologists to document the case throughout surgery. On the left, similar to what our current electronic health record is that we use in SurgeNet, you see medications, and on the right, you can see almost in a flow chart that most of us are used to on the anesthesia side of things or receiving an anesthesia report, where as time passes, different inputs are made that document when the medications were given, when gases were given, such as FiO2, different intakes, and then what monitors were at the time. And finally, I'll pause. I'm not sure if there's any dentists. This is a medical core discussion, but if we did have dentists also have their own electronic health record, and that's called Dentrix. They've moved to largely documenting by pictures. And since there's no dentists on the line, I won't make any jokes about they document in pictures because words are too tough for them. But nonetheless, this is largely a visual documentation tool that dentists have in their own electronic health record. Why did we create a bunch of apps that in the end you'll say, wait, we're all documenting in different places? It's because even though they're documenting in different apps on the front end, on the back end, all the data is flowing into one place. And we'll talk about that a little bit later. So with so many different apps, with so many different providers, again, 205,000 providers, each with their own opinion about how an electronic health record should look and feel, we had to have some way of developing guiding principles to say, when we have a choice to make about what to do, what to buy, how to make things look, what should we look to as guiding principles? These guiding principles were sent all the way up to Secretary of Defense. When the VA, who is now one of our partners, came on board, that was sent up to the Secretary of VA, and these guiding principles were agreed to at that level between the DoD and VA. The first guiding principle we already talked about, that's that we needed to standardize our clinical and business processes across the services in MHS. Honestly, just from our own standpoint, our generation of providers are constantly moving. It's not like the days of old where we just stayed in one place. And it's just a little bit tiring that as we move from place to place to place, the business processes and clinical processes change so much that we've decided that it's more important to standardize as we move forward. Our goal was to be patient-centric. When we started in medicine, for those of us at the time where residency was at the beginning of 2000, we were starting to be patient-centric. I think largely we were provider-centric and focused on that. But as we've moved on, we've realized the importance of really putting the patient at the center of a system that's focused on quality, safety, and patient outcomes. We wanted to be flexible and open in our enterprise solution. And what that meant was the solution that we developed couldn't just work in hospitals. We can't forget that we have an important operational healthcare mission, and that solution for our operational side had to feed in and tie into what we call our garrison side or what we traditionally think of as clinics and hospitals. The most important guiding principle is at the bottom left. And Jamie, at some point, I'd like you, if that's okay, I'll put you on the spot now to share later. Talk about your experience of configuring MHS Genesis for the NICU, and I think that serves as a good discussion or learning point as to how we need to do things smarter moving forward. But our goal was to configure, not customize. Customize means that we make things very special for the individual hospital or clinic, but it might not work at other hospitals or clinics, or that we actually take what we get from our partners, which are Cerner and Leidos partnership, and change it so much that the next time they put in an upgrade, it doesn't work for us. So we're constantly trying to configure, not customize. This serves as a great point just to talk about why we ended up with Cerner versus the other brand. And I did not see a disclaimer that I couldn't talk about brands. There's about 10 of us on the call. So I do want to just address the elephant in the room. Why didn't we get Epic? One, I don't know. I wasn't in the acquisition side of things at that time. And the powers that be looked at the different contracts and felt that the Leidos partnership and Cerner put forward a good contract. So they were selected. But in my personal opinion, looking at what we do in the Department of Defense and then knowing that eventually the VA would want to come on board, I think Cerner was the right call at that time for the electronic health record that we needed to purchase. Epic is like an iPhone. You get it, it's simple to use, but if you try to do anything else with it, it's not going to work. And unfortunately, with our operational component, our readiness component, our mass vaccination requirements, which Epic definitely wouldn't have allowed us to configure their system to allow for mass vaccination. And this was pre-COVID. Thank goodness we were already working on a solution pre-COVID for mass vaccination. Epic just doesn't really bend. It's kind of the Epic way or not. So when it's set up correctly, it's great. But for the number of things we needed to do within the military health system, Cerner was a better solution. Cerner's like Samsung. And the benefit of Samsung is you can adapt your Samsung phone to really do whatever you want. You could customize it so everybody has a different look and feel of their phone. And when you get behind the kind of architecture of how Cerner was created, Cerner's the same way. Little known fact, only the 10 of us will know, but I could actually configure MHS Genesis if I put the time in it, so that all 200,000 people had their own experience. There's a little button behind the scenes, and it's not a button, but let's think of it as a button, where I can set the experience to be just for Commander Alex Holston. I can set an experience just to be for Captain Rep Barrett. I can change the screen color, I can change the screen font, I can give, Rep can be blue, I can be yellow in terms of the backgrounds we want. It is extremely customizable. The problem with over customizing, again, when we get upgrades, it doesn't work and it's kind of hard to maintain. So our guiding principle was to configure, not customize. So Cerner is extremely, extremely customizable to the individual provider level, which has forced us to figure out how to configure, not customize. We haven't always done it right. And that's, again, what we want to get into if we have time to discuss the NICU project that we did at San Diego and are moving forward. One of our other guiding principles, and I know we're spending more time on this slide, but it's an important one, because when we get questions from the field about why are we doing it a certain way, we turn back to these guiding principles. One of the hardest things people have to swallow is decisions are based on doing what is best for the MHS as a whole, not a single individual area. So when we make changes, unfortunately, they have ripple effects in other areas. So simply changing IV medications, which might seem simple for adults, well, actually, we found it affects pediatrics, it affects neonatology. Shoot, it even affects the VA. So it's not as simple to make a change for, say, one hospital that's used to putting in IV medications one way. It actually has to look at for the entire MHS. The benefit to this is that decisions are being made by frontline care delivery professionals. So our decisions about what right or wrong looks like isn't being made back here at DHA. It's being made by our clinical communities, which is largely made up of everybody throughout the MHS. So for instance, I'm a neonatologist, but I don't dictate or say what neonatology should look like in MHS Genesis. Why? I'm not currently a frontline provider. I'm not there every day. I take call every other week at Walter Reed, but I'm not daily seeing patients. So the NICU project was turned over to somebody who was seeing patients on a regular basis, and they were the ones who decided what right or wrong looked like, because they're frontline care delivery professionals. We make rapid decisions to keep program on time and budget. That's more for my acquisition side of things. But unlike legacy, where change would take 6 to 9 months, where you suggested something and then 6 to 9 months later it went into effect, changes can occur pretty rapidly. So when the COVID pandemic started and all of a sudden there was a completely new category of vaccines and a completely new category of laboratory tests, because of how we set up MHS Genesis and really any electronic health record, the changes were able to be made pretty much in 2 days. The longer part was agreeing on what right looks like, but once everybody agreed on what right looked like, the change itself was simple to push forward and make a change. We want to have better communication and training. We're always trying to improve training. We can talk about that frankly at the end. I don't think we're quite there yet. We're making good progress, but I think training and communications could still be improved. And we are building collaborative relationships outside of just the MHS. When these guiding principles were started, we were thinking we were going to join with the VA. Since then, we have joined with the VA, but it extends beyond that, and we'll get to that in a further slide. At the end of the day, the most important guiding principle, though, is we want patients to fully engage in their health. And that can't be understated. So we do things like patient portal and put things in front of the patients so that they can see what we're doing and they feel like they're more driving their healthcare rather than us driving healthcare. I'm going to pause. Is there any questions? Because I spent a lot of time on the guiding principles about the guiding principles. Checking the chat, and I see 2 hands. I'll start with Jen. Do you go by Jen, Jennifer, Commander Ang?
I go by Jen. That's fine.
Okay, Jen, yes.
I just had a question regarding what is the requirement for, sorry, I realized I had my camera covered. The requirement for different departments to use the new, to use Genesis. Basically, at Fort Belvoir, they are still doing paper charts, and we haven't transitioned over to MHS Genesis. But my question is like, can the ER continue to use paper charts if they want to, or is it going to be a requirement that they transition?
Great question. So with very few exceptions, and those are in some subspecialty areas where patient safety is a concern, like some workflows within hematology and oncology, and especially within pediatric hematology oncology, we do require MHS Genesis to be used. So when it comes to emergency medicine, we are forcing the change, and it is a change that leadership needs to lead through, where we're transitioning from paper, which is at Fort Belvoir, to MHS Genesis. The good news is, at least in a lot of departments, so orthopedic surgeons by and by love MHS Genesis. I haven't figured it out. Like usually when I've launched electronic health records in the past, orthopedic surgeons have been the most critical, but they seem to love it. In the ED, FirstNet, because it was designed actually for an ER, and then Cerner bought it and brought it over, and then they just use it as part of their solution. A lot of our emergency department physicians like it, especially when they link it to Dragon Medical, which is one of the tools we brought with MHS Genesis. Dragon is a voice dictation system that some MTFs use it, some don't. But in the emergency department, if you set up your macros and learn from how other people are doing it, the ED people who do that actually love it and prefer it. So to answer your question, Jen, yes, MHS Genesis, once it comes to your site, is a requirement. With few exceptions that continue on paper, everybody is required to do that. Does that answer your question, Jen?
Yes, it does. Thank you. I asked one other question. You said that you're using, sorry, Captain Chauffeur, don't mean to interrupt. But I know that you said that you're using Dragon, but I know that there are also like dot phrases and things that are available in other systems, and even that are being used, at least at Fort Belvoir, to help with documentation. Is that something that is available with Genesis?
It is, and you can actually share dot phrases. It's not the same term, but it's basically the same kind of thought and concept. You can share them amongst providers, you can make favorites and push it forward. Some people have had a lot of success, especially people that kind of thought in that way of using dot phrases before. And then part of the favorites fair, which is something we'll get into, We actually send a team out that helps you set those up before go live. Of course, pre-go live, it's all kind of hypothetical unless you've worked with Cerner or Epic before. So we find that people are like, oh, dot phrases, that seems important. And then some people get it and they're using it from the start, but then other people have to be in the system a little bit and they're like, oh, wait, maybe I should have set up those dot phrases, push that forward. So I see a lot of people use it. Like my style is I think you fall into 3 categories. People that, and this is for people that are writing notes and have a lot of documentation. You fall into the just free text it, dot phrases, and lastly, the dragon folks. I do want to show something if I can. I just want to go back and Captain Shover, I'm going to get to your question in a second, if that's all right, sir. But different than how things were done in the past, we're used to kind of having to write out our notes because Alta was largely a really fancy typewriter, and Accentris, really fancy typewriter. And when I look at kind of how this is laid out, I'm just going to be honest with you. I still think we're about 10 to 15 years behind in terms of electronic health records and how they should look. But now I can tell you without a shadow of a doubt, this is how it looks at every place I've worked in terms of how electronic health records work. So congratulations, you asked for a commercial or civilian off-the-shelf electronic health record. You got one, and they look like this. So different than in the past where we would have just raw documentation, you kind of come down through chief complaint histories. If you look in the middle screen, and I wish I'd figured out how a pointer's working, but I'm not sure if you can see the hand or not. But in the middle screen in the gray column, you come down, you document.
We see it. We see it.
Oh, you do? Good, good, good. History, pathology, home meds, allergies, vital signs, labs. It's almost like all that work we did for the Alta AIM forms translates into MHS Genesis. So if you're used to AIM forms and documenting in that way, this shouldn't be too much of a transition for you. So for those that are used to free texting, that are used to dot phrases or used to using Dragon, yes, that's still there. But for those that are used to using our AIM forms, that way of thinking or kind of going down in terms of documentation is still the same. Come chauffeur. You had your hand raised, sir.
You mentioned this a little bit, and it goes to Commander Overbay's comment in the chat. So I'm not really in the camp of I wanted Epic, and I'm mad that we got Cerner. My real question is, how did we wind up spending $10+ billion on a product that couldn't run drips through children? And we had to have people create a workaround in order to do that. And maybe I don't have the proper understanding of the problem, but that's really my question is, how did we wind up with a commercial off-the-shelf product that didn't seem to include all the bells and whistles such that we could run drips through little babies? Over.
Yeah, good. And the door got propped open, so not as loud as the dog, but this is Hobbs. So say hi, Hobbs. That's why there's a chat with a bunch of backspaces. So we haven't spent all 10 billion just yet, but let's even just keep that down to 500 million. And to answer the question honestly, is it frustrates me as well. And if we could go back in time, I think all of us would have changed our strategy as to what we did. But I'll give you the background because I was there as part of it and have been part of the program since the requirements generation part. The first answer is that we didn't know. And when we looked at buying Cerner, because it was so customizable, people quickly got overwhelmed with the concept that we would have to sit there and go through workshops after workshops to figure out how to customize it. At that time, there was a very strong relationship with Intermountain Health, who also had Cerner. So the thought process was that we would use the customization of Intermountain Health and bring over all the hard work they did and put that as the kind of baseline of our system, so that when we started to actually see how MHS Genesis would work, we at least had a starting point. The problem was when we took that copy of Intermountain Health, especially as it relates to neonates or pediatrics, we took that copy before they had really had an opportunity to optimize their Cerner experience. And it turns out there's a number of different configurations that are required to kind of get things right within Cerner. So that copy was dated and was already known not to work well. When MHS Genesis, and let me get to I'm going to answer your question by putting up a slide if that's okay. In 2017, when we went live at Oak Harbor and Bremerton, and then later went live at Madigan, there was just so many errors, we actually had to take a pause and go back and correct them. And the IOC sites kind of understood that their role in this process was to help to configure MHS Genesis to reality. And the team went out there and spent 6 months trying to figure out what needed to be done. Behind the scenes, it's not as easy as you would think to make corrections. Accentris made it ridiculous easy. That's my area of expertise prior to becoming an expert in MHS Genesis, that if a drip wasn't put in correctly in Accentris, it was easy because I only had to fix it at my local command. I didn't need to have to fix it for everybody. And the configuration stuff to fix it was remarkably simple. Just like I said, I can create Cerner for all 205,000 users. When I go in to change an IV drip, it actually takes a while. So for instance, there was a simple request to change the title of Replogal when it came to neonates because the title being used for Replogal just didn't make sense. So when we went in there to fix it, it turned out there were about 15 to 20 different things behind the scenes that weren't done correctly for Replogal. So even though the request was just, hey, can you update Replogal's name? We had to go back and change about 15 different things so that when Replogal was ordered, it came up correctly. I think to answer your question, why did it take time to fix and why didn't we anticipate this? That's normal procedures when launching an electronic health record. There are very few enterprise sites that get it correct the first go round. Why did it take so long in the NICU and pediatric area to get it correct? I think there was a hesitancy from leadership to really fix everything. There's a balance between deploying and fixing, and that balance said, hey, we have an 80% solution, let's keep moving forward. And until we get to a site that is a larger pediatric site and a larger neonatology site, they didn't change stuff to make it work for NICU and PICU until we had more NICU and PICUs on board. That's not an excuse. Again, this is just my observations between the 10 of us. Don't publish this in Politico, and then we are recording this, and I do see it's going to be on YouTube. So for those watching on YouTube, this is Commander Alex Holston's personal opinion, not the personal opinion of DIMSM or DHA. But we really wanted to make sure that before we started making changes to the PICU and NICU, it wasn't just one institute's NICU and PICU recommending those changes. And that's part of the reason why I took to getting to San Diego to make those changes. Did that at least answer some of the intent of the question, sir?
Definitely, and just so you know, we do usually get a lot more watches on YouTube than we get in-person attendees, just because of the timing and stuff. So, nice disclaimer. Over.
Yeah, roger that, sir. It's the amount of configuration required to get it right is huge. I look at DC Children's. It's one of the local children's hospitals. A number of our fellows who work here at Walter Reed go there, and Cerner's their product. And they say, we love Cerner. Why couldn't we just get that? And I think we forget that DC Children's has been using Cerner for over a decade. I think a decade is how long they've had it. And DC Children's just has to do governance for, gosh, I think one hospital. I don't think they have any other hospitals. And I'm not aware of how many clinics. And so, for instance, in NICU, there's just one NICU. They're not trying to standardize across multiple NICUs throughout the DoD to try to figure out what right looks like. I firmly believe that once we finish deployment, and we're only focused on configuration. We can make Cerner work as well, if not better for us, that as DC Children's does. It's just going to take us time. So while it's helpful to compare us to DC Children's or Boston, who also uses Cerner for their pediatric care, we have to understand that we're just starting out in our understanding of how to use it. And I think we can get there. And that might be optimistic, but we'll see what happens over time. I'm going to pause and see if there's any other questions. So I need to bring this back. See in the meeting chat. And Jamie, we will get to kind of your experience, if that's okay, at the end, if that works for you, and we'll talk about that in more detail. All right, well, I'm going to pick up. So this is the schedule. The important part and the hope I have, and hope's an important word, especially during the pandemic, and as soon as we start to get better, a new variant pops up and it changes how we do things. The hope I have is that we can actually leverage lessons learned from each wave to improve the system deployment process. And that's not just a line, that's not just something I'm paid to say. It's because I've actually been at every go live since Nellis on the ground. No, it was not a hardship to go out to Hawaii. That was actually rather enjoyable. Or excuse me, since Travis, I apologize. But my time in Travis, which is an airfield in the middle of nowhere, an important function for the Air Force, taught me that each wave has been better and better because we are building on the lessons learned. One of the things that we did to make things a lot better is our Pay It Forward program. What the Pay It Forward program is when people who use MHS Genesis actually go to the next site that's going live and help them kind of figure out how to use MHS Genesis. We actually send a team of about 100 to 150 people out each wave who've been at prior sites, in addition to our Cerner trainers, which also number about 150. So you can imagine about 300 people appearing in each wave to try to help people with how to work MHS Genesis. I think you guys understand that whenever we provide care, there's 4 pillars. This is from Colonel Catalina, who's your Chief Health Informatics Officer for DHA. And each encounter has a time, place, provider, and patient. I'm going to go through this a little bit quickly so we have time at the end for statements and questions. But just realize the importance of this and the transition that we're seeing is our old way of thinking was that someone did scheduling, someone did check-in, somebody else did vitals, the provider saw the patient, a document was written, and then billing and coded. And a lot of these functions were siloed. In MHS Genesis, and honestly in any current state electronic health record, so this isn't just us, this is actually how civilian care is done. Scheduling, registration, intake feeds the provider visit, feeds checkout and discharge, and then the document is created by clicking a button, but the focus is in on this workflow. What is a workflow? It's a diagram or a way of thinking about things where we document what work is being done and it demonstrates a flow. Just work, flow. That's all it is. Don't overthink it. Just work and flowing. Behind the scenes is billing and coding throughout the entire process. Every one of these steps feeds into our billing and coding rather than billing and coding coming at the end to document. Now, I know we're providers, but eventually most of us will retire. Actually, all of us will retire. And for those of us continuing to do medicine or clinical medicine, and for those of us who have moonlit, I don't know what the past tense is of it. For those of us who have done moonlighting in the past or worked at civilian programs in the past, absolutely billing and coding is a critical part of what we have to do. I'm going to skip through this slide. One of the other benefits of a lot of the work that's been done by DHA and by DIMSM, who I'm representing, is in terms of standardization, not just in terms of our workflows, but also how we measure things. So one of the hardest parts for leadership was to compare outcomes or patient outcomes from site to site to site, because apples and oranges just didn't mix. So a lot of the work that we've been doing is dividing things into what we call the dot chart. And this is simply for every single hospital or large clinic that we have. All of the metrics for successful deployment is divided into infrastructure, into management, into their readiness. This is dealing with how end users are feeling ready, peer experts, and then usability. And every site gets its own little dot chart that's then compiled for each wave. And we review this weekly with senior leadership. So that's a little bit about MHS Genesis. I'll briefly talk about where I fall, which is DMSM, or DoD Healthcare Management System Modernization Office. And that's under DIMS, which is the Defense Healthcare Management System. This is a PEO and PMO that was set up, Program Executive Office and Program Management Office, to buy MHS Genesis. It's really hard to spend $10 billion and keep it within J6 or keep it within DHA itself. So this was created underneath the USD for acquisition and sustainment. Now that we're largely finishing deployment, this is going to be crossed into DHA, and how exactly that's being done as we move forward is being decided by much more senior people than myself. One of the new agencies to stand up is the Federal Electronic Health Record Modernization Program Management Office, or FIRM. And this agency helps coordinate between the Secretary of VA, Secretary of Defense, and now Secretary of Homeland Security, now that we have the DoD, VA, and US Coast Guard all using MHS Genesis. They do call it something different on the VA side, but it's still MHS Genesis nonetheless. These are some of the key players. So we've talked about health informatics, Colonel Catalina and the office that he represents at DHA. DHA also has a medical device integration office. We'll talk about medical devices briefly. And then J6. Hey, fully aware, unless you've come to DC, that all of this is just a nice little black box. So I only tell you this because it helps us to hear the terms. You can go back and look at the slides. I'm very comfortable that whenever I'm outside of DC, I just refer to everybody inside the Beltway as them. And whenever I'm in DC, then I figure out who all these people are. But you can just call us them for those not within DC, and I'm completely comfortable with that. In terms of who we work with, we do have a vendor, Leidos Partnership for Defense Health. I can tell you that working with a vendor on the acquisition side is a little bit different than what I was used to, but it was helpful for me in my learning and education to spend these past 3 years doing that. But otherwise, just know that when we deploy MHS Genesis, in addition to us, there's Leidos, there's Cerner Corporation, Henry Schein, and Accenture Federal Services are all teammates and support us in our deployment. We are deploying in 2 different segments. So segment 1 is what we traditionally think of as MHS Genesis. Segment 2 is going to be our forward operational forces. The work for segment 2 is still being done. It's an important part of what we do. This is our wave schedule. And just, I think this tells a better picture. So just, you can reference this in terms of if you're wondering when you're going to get MHS Genesis. So for instance, today, a lot of people are already doing the command executive brief at Walter Reed. So that's where my senior leadership is. We're kicking off Walter Reed and Belvoir. We already had our kickoff at Portsmouth and Wave Drum. What was really neat is we now have our commanding officer who's been through 2 go lives. So 1 go live done, 1 go live pending. Now that we have commanding officer at Portsmouth who used to be at Pendleton. This is the more impressive part. So we've already deployed to 1,000 locations. We have 64,000 active users, 17 states, 47 MTF commands. And by the time I come down to Portsmouth, we would have deployed to Texas, which will make us well over half of all sites using MHS Genesis. I did promise I wasn't going to retire until all of us were on MHS Genesis. That looks like that's coming true. So everybody should be on MHS Genesis before I plan to retire. That way you can complain to me until I retire. This is just a different way of showing what we have coming up, but it's the same information. When it comes to deploying MHS Genesis, there's a number of different functional areas that we use. I'm going to go through these pretty quickly and make it relevant to us, but just realize that those of us who aren't medical corps or might not be medical corps, there's other key functions for you as well. The one that's important for us is the Informatics Steering Committee. Most sites in the Navy already have that set up, and that's a committee that brings together people that are informaticists that kind of serve as that integration point between technology and how we do things in a clinic. This is just looking at the timeline for each individual site in that effort to make sure that we make time for people to ask questions. I'm just going to kind of scroll through this. You're going to get this information when MHS Genesis go lives, and since we already have some people who have already gone live, this is just redundant information. This is a different way to break down the roles and responsibility. MTF leadership, I've read a lot about how to deploy electronic health record. I'm now, for those of you interested in certification, there is a board certification for clinical informatics. A number of us have gone through that process, so I'm actually board certified in neonatology and clinical informatics. And the more you read about it, the more that any cultural change needs to start with senior leadership. And that's evident to those of us in the military, which is why the project sponsor should always be the MTF leadership. This gets through into the individual business roles and clinical roles throughout Go Live. And I'm just going to kind of scroll through that because you guys can read just as well as I can. I do want to finish with, not only are we changing the way you document, but we're actually changing the way we provide care throughout the MHS. And we're coming to a more modern way of doing things, which is actually safer. And part of making something safer is it does make it a little bit more frustrating at first. But I can just tell you that there have been so many patient safety issues resolved by doing it using a modern electronic health record. The most important is barcode scanners. So it works most of the time, and we're still getting the kinks out. But by using barcode scanners, nurses actually scan the medication and the patient wristband prior to giving medications. I hate going to a patient and telling them, at least in my field, that we've given the wrong breast milk. So part of this is we are looking to build in the same barcode scanning into breast milk. But you just one time explaining to a patient, hey, I'm sorry we gave you the wrong medication, all of a sudden realizing that the importance of using equipment to make things a little bit easier or safer, such as barcode scanners, becomes important. So this is the different equipment that you'll get when we provide MHS Genesis to your sites. Where are we going in the future? We have a lot of things, but none of this should be a surprise. We're working closer with the VA. We're working closer with VA benefits. MTF's population health, we're launching some new capabilities that are going to make that a lot better. And we can talk about that if that's what the audience wants to discuss. We are looking to make patient movement throughout theater an important part of our next step. That's not through DIMSM, that's through a different program office called JOMIS. And we are looking to improve our health information exchange with the private sector. As of today, we have the largest health information exchange in the nation. We currently are exchanging information in the private sector with Commonwealth, which is one of our health information exchange platforms. We're exchanging information with the VA and the DoD. One of my projects that I'm working on, and actually I'll continue to work on even after PCSing, is onboarding new federal partners. So I can say that these are just the current federal partners that we work with. But in the future, we're looking to onboard NOAA. We're looking to onboard NSA. Indian Health Services may or may not onboard with us. They have a different way of purchasing electronic health record. So we'll have to wait and see what they do. But a number of different agencies have decided that working together, it's easier to achieve things. So look for more, not less. Of note, my brother is a retiree within the U.S. Coast Guard. He currently receives care from Walter Reed as a patient and a VA beneficiary. So neat to me was that Coast Guard has gone live at every clinic. So they were actually the first agency to finish deployment of MHS Genesis. Not only are we MHS Genesis in the terms of the electronic health record, but Video Connect is a tool we never thought possible. It's actually a Video Connect tool that patients can use for virtual care on our networks, which means it's cyber secure, which is an important part of what we do. And I was just at Thanksgiving dinner and my brother was saying, hey, have you heard of this new Video Connect thing? If you want real patient experience, my brother's able to stay home, get his care at Walter Reed. He lives about an hour and a half away from Walter Reed. And it saves him a weekly visit to Walter Reed because it can all be done through Video Connect. So modernizing is important, but at the end of the day, it needs to be patient-centric. And that's largely what we do. Hey, I left only 9 minutes for questions. So I do want to pause and I want to turn it over to Jamie just to share your experiences in neonatology. If you don't mind, Jamie, I'll put you on the spot for a few minutes.
Yeah, that's fine. So like Alex said, I'm Jamie Overby. I'm the medical director of the NICU here in San Diego. We went live with Genesis in February of 2021. Like most people taking on a new EMR, there was resistance to change even before it went live. But we did a lot of preparation and working with Madigan, who prior to us was the only NICU that had been live with Genesis. So we knew there was going to be certain frustrations that we were about to face. Like Alex mentioned, there's the configure versus customize. And so we knew it wasn't going to be what we had previously worked with, like with our version of Accentris. And so we tried to tout the mission, like, this is, you have to help the provider fit Genesis. Genesis isn't going to change to fit the provider. And that's hard for a lot of providers to understand and agree to. So we knew that there were some struggles. We dealt with those for a couple of months, but when you hear workaround after workaround, and we talked to our colleagues at Madigan and said, hey, we're coming up with these problems, you know, are you seeing these same things? And when you hear yes from the other facilities, and you see this being a problem in the future for all future NICUs and even any neonatal care, that's when we kind of said, hey, this is a bigger problem than just a single MTF, and it needs to be fixed. Like Alex alluded to, I think MHS Genesis went live with at least a NICU platform that was not ready to be used in the patient care setting. And that became very obvious when we started using it. Now, what led to kind of our patient safety stand down, that was, you know, after a few months. So we went live in February. The patient safety stand down occurred in May. When I was hearing things from multiple providers and recognizing things myself, it was up to me as the medical director to decide, hey, can we deliver safe patient care with this system, or does something need to change before something bad happens? And that's where, working with my leadership, we decided right now we can't deliver patient care that's safe confidently. And that's why we needed to act on that. So we shut down our NICU. We talked to the people at DHA, Alex included, and said, hey, these are our top things that are preventing us from providing safe patient care. The top things being medication drips and IV fluid administration. Now, if you ask the providers here, there's probably 300 more trouble tickets that we put in that we wanted things fixed, but those were more of the customization, things that we wanted specific to us, and they didn't prevent us from providing safe patient care. And so we needed to focus on those two big things that said, hey, if we fix these, we can go back to providing care that we know is safe for the patients. And so we were shut down for 3 weeks. We disengaged over 15 patients. It was close to $1 million in purchased care that resulted from that. But, you know, we got the attention of the people at DHA and Alex's group, and we were able to work through it. Now, like Alex alluded to, it's the medical professionals that are making the decisions on the edits and the builds and how you're going to make Genesis work for you. That's good and bad, right? You have the frontline workers. We're using the system. We can say, hey, this isn't working and this is why. The bad part is you have the same people who have a full-time job being a doctor now trying to help you fix the system. And the bandwidth to do that, it's hard. I mean, when we shut down, Dr. Knickerbocker and I were able to allocate a lot more time to going through 120 plus IV fluids, 50 IV drip medications, because we were still taking shifts, but we didn't have as much patient care responsibility. Now, when you go back to doing a full-time doctor job, plus all of your Navy collaterals that you need for promotion, and now you're adding, oh, by the way, I hope you have a minor in IT to help rebuild Cerner. That's really hard. And that applies to pay it forward as well. I agree, like when we went live, we didn't have any clinical pay it forward person with us in the NICU, and that was not good. We had some, what I call buttonologists from Cerner and Leidos that helped us find our way through the system, but we didn't have somebody that could help us with workflow. Now, we would love to go to every NICU and help them learn from, what our mistakes and what our lessons learned were. But at the same time, I have a mission here at San Diego for patient care and readiness, and I can't necessarily meet that mission if I'm sending people off throughout the country to go to future go lives. And I think that that's something that hopefully, as more sites go live and we have more pay it forward opportunities, that we'll be able to spread that wealth and have those clinicians there on the deck plate helping with go live. But in these early phases, that's been something that's a real struggle. So I think as more sites go live, you do have to pay attention to, hey, what's annoying and would be a nice fix versus what is a actual patient safety inhibition to delivering patient care that needs to be fixed. And those are the things that need to have the red flag raised and brought up through leadership and addressed in a timely fashion. And it's hard to differentiate wants versus needs, but it's something that you have to do to work through, because also, like Alex mentioned, there's not hundreds of people sitting at DHA that when I say I need an IV fluid order fixed, they get their team in and they just fix it. It's a couple people from pharmacy who are also spread across the nation working at various MTFs, doctors like myself contributing to this, and also on like the clinical communities at DHA. And so there's not just this plethora of people waiting to fix things. It's the deck plate people that are involved with that. And that's going to be an ongoing struggle moving forward. I'm happy to field more questions offline specific to the NICU situation or other lessons learned here. But if there's any questions, I'm happy to field them now as well. Over.
Thank you, Jamie. I'll pause for any questions from the group. I'll look for raised hands. Captain Chauffeur?
Hey, I have a question for you about data. When I was the healthcare business director like 3-4 years ago at Portsmouth, every time we would see slides, the Pacific Northwest would be blacked out because they were using Genesis and no one had any data on their appointments and productivity and patient, access, third next available appointments. What's the current status of what kind of data we get once Genesis goes live, and has that been resolved? Over.
It hasn't been resolved, so I'll start with that, but it's a lot better than it was when we first started. We were never without data. We just had too much data because we're using a modern electronic health record. So the efforts that have been really paying off is kind of standardizing the apples to apples comparison throughout the MTFs in terms of how we conceptualize what is and isn't important. And I can now say that every time we go live from day one, we start tracking data such as ER wait times, length of stays within the ER, barcode scanning, which has become an important part of at least senior nursing in terms of patient safety, and other metrics that really fill a whole page worth of metrics that DHA has decided this is how we're going to judge how well a hospital is doing. So we're no longer data blind. Where do we struggle is a lot of the terms that we used, third available appointment, were designed around our old electronic health record and old workflows. So there is some data that we're trying to figure out, how do we really get to what does that measure mean and what are we trying to measure? That we're working with the clinical community to say, hey, we can't measure this exactly in MHS Genesis the same way, but we have this data available. Does this get to the root of what you're actually trying to measure? In terms of patient outcomes in national standards, because it's a clinical off-the-shelf electronic health record, that part's actually pretty easy. A lot of the standards that are used nationally are kind of pre-baked into Cerner. So as we adopt those, a lot of people are experiencing a lot of success in using MHS Genesis when it comes to that data. So no longer a problem. Does that answer your question, sir?
Yeah, great. Thank you.
Any other questions for Jamie or myself? All right, well, I see we're at the top of the hour. So Jen, I'll turn it back over to you.
Wonderful. Thank you so much. Thank you everyone for joining. This will be posted on YouTube, and I will send out the link via social media as well as in Captain Chauffeur's emails. So thank you so much, Commander Halston. I really appreciate this presentation and answering all these questions. Thank you, Commander Overby, as well, for your input. I appreciate that as well. And I will stay on the line just in case there are any last minute questions, but I will stop the recording, and thank you all for joining today.
Thanks, everybody.
Thank you.